Thank you very much, Mr. Chairman. I appreciate it. Thanks for holding this very important hearing. I'm constantly reminded about the importance that Medicare plays in the lives of my constituents when I'm back in my district in Florida, in the Tampa Bay area. In 2012, there were about 145,000 Medicare eligible beneficiaries in my district. Medicare is an important program. I want to make sure whatever we do in Washington that we protect current beneficiaries and future beneficiaries. We need to make sure that Medicare is on strong financial footing to be there for our parents, for us, and for our children. Senator Lieberman and Dr. Revlin, in your Medicare modernization proposal, you talked about providing a unified deductible access across Part A, across Part A and B. Can you talk about how this would provide clarity to seniors when understanding their Medicare benefit and discuss how this would reduce overutilization?
Thanks, Congressman. Just very briefly, it's actually very hard to describe the current system of deductibles under Medicare. It's so confusing. So I think the first benefit of combining Part A and Part B into a single deductible, Senator Coburn and I recommended $550 annually, is the clarity. And incidentally, in most private insurance plans, there is a clarity on deductibles. And there's no reason why we shouldn't give the Medicare beneficiaries the same clarity. The second hope, obviously, is that that as you create that clarity, you will create in the beneficiary a kind of second thought about overutilizing services. You don't ever want anybody to not go to the doctor because, or the hospital, or get a prescription drug because they're worried about the cost. We're talking about hospitals and doctors in this combined deductible. But there's clearly overuse. I mean, one of the more controversial recommendations we made, but it's been included in some of the other studies done, is to limit the availability of the Medigap coverage. Because, for instance, not to have it pay for all of the deductible and have it pay for a limited amount of the out-of-pocket, because there's study after study that show that people who have Medigap use 25% more of Medicare services than people who don't, without any discernible increase in health care results. So, look, if we're going to solve this problem, everybody's going to have to help do it, including the beneficiaries. And this is a way to try to incentivize them not to stop going to the doctor or the hospital, but to make sure they need to before they do.
Thank you, Dr. Rubin.
Yes, I agree with that, and especially would like to emphasize the part about about Medigap. The effect of Medigap very often is to make health care free, and when it's free, you tend to overuse it. So putting some limits on that, I think, is important. But one other proposal that often goes with restructuring the deductibles is to put a limit on the out-of-pocket costs, which we don't now have. That would be that goes in the other direction. It would cost something. But it would be a big benefit to especially low-income seniors who run up against high out-of-pocket costs.
Yeah, and that was one of the gives and takes, excuse me, Mr. Chairman, that Tom Coburn and I were involved in. So we did what we just did about the deductible and Medigap, but Tom agreed that we should put a limit on how much out-of-pocket a Medicare beneficiary would have to pay, and that'll have a significant real but also psychological effect on our seniors.
Interesting. But I have one more question, Mr. Chairman. Dr. Rivlin, in your testimony, you mentioned one idea was rewarding beneficiaries for using generic drugs. Can you elaborate on how to incentivize beneficiaries to choose lower cost options?
Yes, I think it's often the beneficiary doesn't care whether the doctor prescribes the generic or the brand name. It doesn't matter to them. It should matter. They should pay a little less if the generic is prescribed.
Okay, thank you. I yield back, Mr. Chairman.